Well, tonight we're very fortunate to have Dr. Shelley Spanner here to speak with us this evening. She's a radiologist at Mayfair Diagnostics, professor at University of Calgary, and on the board at the Prostate Cancer Center. She's previously served as the Department of Radiology liaison with the undergraduate medical education program at the U of C and has been recognized with multiple teaching awards. She spoke to us last in September 2014, and since then she will update us on current imaging guidelines and protocols, as well as some of the research that she's doing in regards to imaging, and provide a look at what's on the horizon for prostate cancer. Thank you, Dr. Spanner.
It's really great to be back. I can't believe I got asked back. So, Stuart, I think that's partly you. And Kelly, thank you for having me. I am going to turn down the lights just a bit, and I'll speak into the mic because I know I speak softly. Please feel free to interrupt me at any time. Like, this is a time for us to kind of share our experiences and our knowledge. I'll try and share my knowledge, but I'm sure you all have some experiences or some things that you might want to interject with, and feel free to interject at any time. I did make some objectives for today. I'm going to review the diagnosis of prostate cancer. I know most of you are well aware of what that is, but there might be a few people in the room that would still like to know a little bit more about that. I'm going to review our current Alberta Health Services imaging guidelines and protocols for patients that are diagnosed with prostate cancer. I'm going to discuss PSA screening and where we're at now. All of you are probably aware it's a controversial subject, and I'm going to talk to you about it a little bit, up to date, and then discuss the resurgence of MRI and its potential role in management. It certainly has become a hot topic of conversation, gaining momentum since I was here last, so hopefully we'll be able to give you the new knowledge. Most of the resurgence has come about because of PIRADS 2, and however, I was speaking with somebody just before we started and already well aware of that. That's just the imaging, reporting, and data acquisitions steps that are used that are standardizing imaging, and I'm going to describe that in detail and explain it to you. I've got a few case examples just to show you that we do have some successes. We're not perfect by any stretch of the imagination, but we're certainly moving forward in the right direction, in my opinion. So we all know that prostate cancer is the most common male cancer, and we get 2,500 new cases each year in Alberta. Second leading cause of death in American men and in Canadian men, actually. And the one thing that we're all happy about still is the 5-year survival when it's localized to the prostate gland is 100%. So in 80% of cases, men have 100% survival with this disease. So in terms of cancers that you can get, it's not the worst one to get. If you've got regional spread, which happens in about 12% of cases, your 5-year survival is still close to 100%. And that's where we want to catch people. And that's why still in the majority of, well, in all of the Southern Alberta Institute of Urology's guidelines, and all the urologists there strongly believe that preventative screening is the most important thing to make sure that we don't see men late distant spread, because when you've got distant spread, your 5-year survival has dipped off significantly. I'm going to just go through the histology of I don't quite know if my mouse works. Oh, it does. I'm going to go through what prostate cancer looks like, and the reason I'm doing that is imaging takes advantage of what prostate cancer looks like histologically. So anyone who gets diagnosed with prostate cancer, more than 95% of the time, it's an adenocarcinoma. The rarer kinds are sarcomas or mixed cancers or metastatic disease from another source, but 95% plus are adenocarcinomas. And the problem, or one of the challenges of prostate cancer, is adenocarcinoma is multifocal, so it can be anywhere in the gland, and it's heterogeneous. So some of the cancers are low grade, some of them are high grade, and you can have both of those types of cancers in the same gland. This is a histologic slide of a prostate cancer, of a normal prostate gland, and this is the prostate cancer. So in a normal prostate gland, you get glands and you get intervening stroma, and it's very organized, and in each cell there's one nucleus, and it's a very pretty looking slide. When you get cancer, histologically, it becomes much more heterogeneous, And, yeah? I can speak into the mic. How about if I hold it? Oh, you know what? I bet you the mic, is that better? The mic is on now. Ah, the mic was not on. Whoa, I am an idiot. How about I can leave it still? Now, can you still hear me? Okay, sorry. I won't start over because that would be boring, but I'll try and speak up now. So the initial slide here is normal prostate tissue, normal glands and stroma, and it looks very organized. Prostate cancer ranges from disorganized, right here, kind of just a mess of cells, to still maintaining some organization. So it's a diffuse pattern of high-grade and low-grade cancers with little intervening cells. When you get cancer, the cells become more dense. You get less intervening normal parts of the cell, so you get less water, you get less normal cell, and that's what imaging takes advantage of, and I'm going to show you that in a few minutes. But it correlates perfectly with T2weighted imaging, which looks at water content, and diffusion-weighted imaging, or DWI imaging, which looks at how cells move in the body. So the histology is difficult. It's difficult when you're learning it, and it's difficult, but it correlates beautifully with imaging, so we have to take a look at it. The other thing that cancer does is cancer in any part of the body is abnormal cells turning over quicker than normal cells. And to do that, they bring in new blood vessels, or angiogenesis. They bring in these ugly-looking little vessels that cause early enhancement of the tumor, and we also take advantage of that. And that's correlated with the DCE, means dynamic contrast enhanced images, which is what I'm going to show you in a couple minutes. You've all heard of your Gleason stage for your cancers, so I'm not going to spend a lot of time on it, but you know that the grade is based on the architectural pattern of the cancer. So if you've got a Gleason 1, you don't really have a cancer. You've got small uniform glands. Gleason, and the Gleason stages are 2 scores mixed together, so added together. You get 1 score for the most common type of architecture and 1 score for the second most common pattern of architecture. So the lowest Gleason score you can have is 2, 1 plus 1, and your Gleason 6 is a 3 plus 3 or a 2 plus 4. Your Gleason 7 is a 3 plus 4, and your Gleason higher than that is Gleason 4s and 5s. So that's how you get the range from 2 till 10. 2, 3, 4, 5, and even 6 are basically very low-grade cancers. You're probably not going to treat, you're going to watch. And when you get a little bit higher grade, 7, 8, and 9, and 10, that's when we have to start worrying. The stage of the cancer is based on the size of the tumor, the location of the tumor, the extra prostatic extension, and if you have or you don't have extra prostatic spread or metastases. The grade of your cancer and the stage of your cancer correlates perfectly with your stage of with your prognosis. If you have Gleason 6 and it's confined, you have a 5-year survival of 100%. If you have a Gleason 8 and it's not confined, your 5-year survival will be much lower. So when is imaging used? We talked about this last time, so some of you, Stuart was here last time, I'm not going to bore you with this, but some of you have been here, Norm was here last time as well. Some of you have been here before, but we use imaging when you present to your doctor with an elevated PSA and or you have an abnormal digital rectal exam. And the first imaging that we use is ultrasound. We use ultrasound to guide the needle biopsy and to confirm the suspicion that you have prostate cancer. The 5 to 7.5 megahertz probe is what we use for standard treatment. There's lots of research going on, including at the SAIU, about increasing the megahertz of the probe. They're using up to 20 megahertz probes to try and see if you can actually see the cancers. Still a work in progress, not well supported yet by anybody. But when you do a transrectal guided biopsy, you put the rectal probe in, and from that rectal probe, you take a series of 12. So this is the rectal probe here. This is the prostate gland on ultrasound. And you simply take 12 sextant core biopsies. So you spread your cores around the periphery of the prostate gland, take 6 cores, 2 in each spot, and get these 12 18 gauge samples. So 18 small core samples. So you can see yourself that there's going to be a large number of overcalled and undercalled cases because you're basically taking 12 tiny little cores through a prostate gland that can range from 30 cc's to 90 cc's. We often talk, it's not a joke, but when women discuss prostate cancer, breast imaging and breast screening is a correlate that we often use. And any woman would say, I wouldn't in my right mind let anybody do a random core biopsy of my breast. So I still don't understand why men do. And unfortunately, it's still the only way to actually sample the prostate gland at this particular point in time, although I'm going to talk to you about where we're going and how we're doing better in that. You can imagine when you do the random sextant biopsies, you miss a lot of the prostate gland. You particularly miss anteriorly because the probe doesn't hit as far anterior as a lot of men's prostates go. And you take only less than 1% of the gland volume most of the time. So you're sampling a very small portion of the gland. So you miss cancer in between 10 and 38%, so that's not very good. And you underestimate the Gleason grade in close to half of the cases, which is also not very good. As many of you may already know, the over-detection of low-grade cancers is a big problem. You treat patients who would not die or would not even know they had prostate cancer, and the under-detection of the clinically significant cancers is also a problem. So transrectal biopsy still has huge limitations. Hasn't changed. But it can give you your diagnosis of prostate cancer. And then in terms of imaging, what happens next? Well, you have to decide if the cancer is confined to the prostate gland, because that would be great, and then that helps stage the prostate gland, and you have to decide if it's moved. So this helps you decide if you're going to stay in active surveillance or if you're actually going to treat your cancer with curative intent. So you, of course, get a history and physical examination done. You get the relevant blood work done. Your PSA, which should be done before biopsy, it'll rise right after your biopsy because you've got the inflammation and the trauma from the biopsy, so you don't want to look at that PSA very carefully. You want to see the pre and the 6-week or 6-month post, depending on your urologist. If your grade is high and your PSA is high and your stage is high, the next step is a nuclear medicine bone scan, which I'll show you, and that's still saved for patients with high-risk disease. CT imaging is also saved for patients with high-risk disease, and I'll show you a couple of images of that. So some of you will have had a nuclear medicine bone scan. It's primarily used to determine if you've got bone metastases, because that will change your treatment. So it's indicated only for those with high-risk disease, so elevated PSA and a high Gleason score. Basically what you do is you get a radioisotope inserted into your blood vessel, into a vein, and it tags a nuclear, there's a radio tracer that's tagged to look at bone turnover. Wherever the bone is turning over quickly, it'll emit a gamma ray, and the gamma camera, so you will lie here on the bed, you'll have a radioisotope running through your veins. 3 hours after you get that radioisotope injected, you will be imaged under this camera, and this is a gamma detector. So it will give us a pattern. I'll show you an image. It'll show you a pattern, and anywhere that your bone is turning over quickly, it'll show a hot spot. So this is a normal case, and you'll see kind of increased activity along major joints. So your shoulders that you're using all the time should be bilateral and symmetrical. Same with your hips. This is unfortunately difficult to look at the prostate gland because the radioisotope is excreted into you get rid of it through your kidneys and your bladder, so the bladder always has some increased activity within it, even if you go to the bathroom just before you're imaged. So that's a normal case, and this is an abnormal case. And so this doesn't, first, it looks ugly, and it is ugly, unfortunately. It's a patient that has bone metastases, so they've got abnormal turnover in their pelvis, and then in multiple spots in their spine, and then in multiple ribs. And so this is a patient with prostate cancer metastases, unfortunately. The nuclear medicine bone scan can be active in other things besides metastases. So say you had a rib fracture, it would look the same as a bone metastases. So you have to see each study with a grain of salt and make sure you know exactly what you're looking at. Oops, the wrong way there, I think. Okay, this is what the plain films look like. This is an x-ray of a patient that has bone metastases, and all these little white spots throughout. This is the pelvis, femur, kind of the obturator portion of the pelvis, and you can see all these little white spots are bone metastases. The increased density of the vertebral bodies is also what bone metastases look like. CT is a different type of imaging. It, instead of the patient emitting the radiation from it being injected into them, the machine emits the radiation. So in this CT scanner, there are, in Calgary, the machines that we use have 126 radio active sensors that will circle the body and create the images. So it's only done if you've got a Gleason 7 or higher and you're being considered for treatment, so high-risk disease, and it's used for staging. CT is not good at all to look at the prostate gland. This is what the prostate gland looks like on CT, just a homogeneous gray gland. Behind it sits the rectum, and that rectum has a bit of oral contrast in it. That's why it's got a bit of whiteness. This is the bony pelvis, so the symphysis pubis, the top of both femurs, and the top of your acetabulum. And the other gray structures around are just the supporting muscles, the gluteal muscles, the pelvic muscles. So the prostate gland is a very bland organ on CT. CT doesn't help you at all with prostate cancer. It doesn't help you at all. It's not useful. So don't let anyone tell you that it is, because it's not. But what CT does help you with is looking for lymph nodes. And prostate cancer, when it spreads outside of the gland, has a very organized, almost like a soldier's marching along the lymph node chains. It has 9 stations that it goes to, and CT is perfect for picking those stations up. This is what a lymph node looks like. You have to have a little bit of, you have to have seen things a few times. I'm just going to go back to, blood vessels can look like lymph nodes, so you have to be really careful. Adjacent to the iliac vessels are the iliac lymph nodes, and that's a pathologic node. This is a patient that has much more severe nodal disease. CT takes 3-dimensional images, but we're looking at an axial image, so front to back. So if you think of yourself standing there, you're going to have an axial image through the small amount of fat that you have in your anterior abdominal wall, your anterior abdominal wall muscles. There's a little part of the liver here, a little part of each kidney right here. The big vessel in your abdomen, the abdominal aorta, sits there, and all these big gray nodes shouldn't be there. And so that's what nodal metastases look like. So that's what we do right now in Alberta Health Services for the majority of our patients that have prostate cancer. They come in with an elevated PSA or a digital rectal exam that is worrisome. They get a transrectal ultrasound guided biopsy. If they've got a prostate cancer with a Gleason 7 or higher, they get staged. So they get a nuclear medicine bone scan and or CT, and sometimes both CT imaging. But that's not very, still not very good, right? We miss a lot of cancers. No, that's not true. We don't miss a lot of cancers. We don't know what to do with a lot of the cancers that we get. So we get low-grade cancers. We're not sure what to do with them. We're not sure we have the whole tumor burden. We're not sure if we're staging properly. And there's still so much uncertainty. Much better than it used to be, but we're still needing better. And so we are getting better. There's so much new technology. We talked last time about high-resolution ultrasound. That hasn't taken off as much as we'd hoped. The contrast-enhanced ultrasound has some promise and is being studied more than it was, but still not as great as we'd hoped. But the multiparametric MRI, which I'm going to spend the next 20 minutes or so talking about, has really come a long ways, and it's given us a lot of hope. So I'm going to talk about that. Molecular imaging is also moving quickly, and really at the Prostate Cancer Center, we've got 3 or 4 trials that are incredibly promising. Those of you who are up to date on the United States work or the work in Europe, very promising. So that's helpful. I'm not going to discuss these, but these are some of the sequences that you'll see if you're reading the journals. And all of these have pros and cons. They all look scary if you're not a scientist or you haven't read a lot of things, but they all can be broken down into very simple, different ways of using MR technology to interrogate prostate cancer. I'm not going to spend time on those because we're not using them. I think I put this slide in last time. If I didn't, I love this slide because I was sitting next to somebody at an event and he was adamant that his dog could smell his prostate cancer, and I love dogs, so I was like, okay, I'm going to find that. Before I start about MR, I just want to talk about the controversies because I'm sure that some of you are well aware of that, and we'll talk about it and where we're at. So there has been a 44% reduction in prostate cancer mortality in the last 20 years. That's not controversial, it's true. What's controversial is this attributed to PSA screening? And in our center, we think it is. 100%, we think there's no other reason for that. The United States Preventative Services Task Force in 2012, so I'm going to give you the update because it's the exact opposite of this, which is not great, but the United States Preventative Services Task Force, which took 70,000 men and studied them, they recommended against PSA screening. And they said the overdiagnosis and overtreatment was too much. They couldn't bear it. So the PIVOT study, which is procedural intervention versus observational trial, suggested we've got to find a way to find the aggressive cancers. That's where MR comes in, and that's a really important study for those who are trying to figure out how we can do better. Just this year in March, the New England Journal of Medicine, which is used by everyone, urologists, family docs, every single medical person, still thinks this is the journal of the Bible of medicine. So what they say, you take very seriously. And they said, okay, we still have no clarity about the usefulness or desirability of routine PSA-based screening after 25 years and 2 large trials. That suggests there hasn't been, PSA screening is likely not more than marginal. And when you take your oath and you say do no harm, it seems reasonable not to do this. We disagree though. We still think there's nothing better, so PSA screening is still the best that we have, but the New England Journal of Medicine also goes on to say there's a critical need for strategies to reduce the burdens of diagnosing indolent disease and treating it or not finding it in the first place. And that's the most pressing research challenge, and that's where MR comes in. So how do we use it? And this is the role. So MR is not new. We talked about it briefly in 2014, and I introduced it, but when it was introduced in the 1980s, it really didn't have a great following. It didn't help the urologists. It didn't help the surgeons. It had, if you showed an MRI to 4 different radiologists, you'd get 4 different interpretations. So it fell out of favor. And it's still having a hard time coming back into favor with some of the urologists, but we're beginning to prove to them that it's a very useful study. So I'm going to try and make it easy. Those of you who are tired and now it's going to be fun. So this is the fun part. So when you see MRI, you're already thinking, oh God, what are they talking about? They're using these big words and nobody's going to know what they're talking about. All it means is multi-parameters, so multiple parameters of imaging the prostate with MR imaging. That's it. That's all it means. And there's 4 different sequences that we're going to talk about. Oops, I'm going to try and go in the right direction. These are the 4 of them, and we'll go through them. This is a T2weighted image. This is a contrast-enhanced image, and these are the beautiful diffusion-weighted imaging and the ADC map, which I'm going to talk to you about and bring back to the histology. All of the MR that we're going to show you now, we'll come back to that histologic slide that I started with. I just wanted to show you one thing, though. On the T2weighted image, this is what the prostate gland looks like, and you can already tell that it's way more complex than what I showed you on that CT image where it was just that gray, blurry, round structure. Okay? So the anatomy of the prostate gland is a bit complex. It's got a transitional zone and a peripheral zone. It's got a central gland, but you can see it all on MR. So you've got your peripheral zone, your transitional zone, and the anterior fibromuscular stroma. Those are the three parts of the gland. So when somebody says, well, prostate MR is so difficult, it is difficult, it's challenging, but when you think of your looking at the liver where there's like 100 different vessels and there's 55 different tumors, prostate MR is not that hard. But there's a few things that we have to go through to make it a little more simple. When we're looking at the transitional zone, our most useful sequence of MR is the T2weighted image, which I'm going to show you. When we're looking at the peripheral zone, which is where about 85 to 90% of the cancers occur, we use the diffusion-weighted imaging. And remember, the diffusion-weighted imaging is that physiologic sequence that takes advantage of, remember when cancers, they take away the water in the cells, so they restrict the diffusion. If you think of those cancer cells don't have room to move around because there's so many of them, the motion of them is restricted. So restricted diffusion shows up as a bright spot on diffusion-weighted imaging. And it's beautiful. I'll show you some of the cases. Okay, so the T1weighted image, and this is for those of you who might have an imaging background or in MR, T1weighted imaging in every other body part is the most useful for anatomy. Every other, the brain, the shoulder, the knee, the liver, every other body part, T1weighted imaging shows anatomy, but not the prostate. It just looks exactly like that CT imaging. It's just a gray blob in the middle of the pelvis. So this is the symphysis pubis. You've got a little bit of fat, which is bright. The prostate gland and the rectum sits right behind it. So what we use it for is we use it, those of you who've had biopsies, when you have a biopsy, there's blood products that sit there for up to 6 weeks, 8 weeks, 12 weeks. And the blood products change color, or change signal intensity, not really color, excuse me, over time. Hemosiderin, which is this really bright blood product, will totally make your interpretation of an MR impossible. So those of you who get a biopsy and then say, I want my MR done, you can pay for it, but it's going to be useless because your whole prostate gland is going to have this blood right through the peripheral zone where the biopsy goes. For me, what I've found when we do this, because I do work at the private clinic, I don't advocate private clinic, I'm a public medicine person, but I work there because that's my job. What I found is that I love to see these because it shows what part of the gland has been missed, and it's helpful with that idea because you can see where this person's biopsy was. They've got all this hemosiderin and blood products where the prostate has bled secondary to the biopsy, but all the rest of the gland has actually been missed in the prostate biopsy. So again, if you want a prostate MR, make sure you listen to the radiologists who say don't do it within at least 6 weeks, because if you do it within 6 weeks, they'll definitely take your money, but it will be a useless study. And here's another example. This is another patient who had, this is a T1weighted image again. They've saturated out the fat, so all the fat, instead of being bright, is now black. So it just makes everything stand out a little bit more. But you can see all the spots of the prostate gland that were missed in the biopsy. So that's not great. The beautiful thing about T1weighted imaging, or the major use of it, is it allows us to detect skeletal metastases and nodal metastases that may or may not correlate with the other staging that you've done, but it's useful. So T2weighted imaging is your first image sequence. It takes about 3.5 minutes to acquire the images through the prostate, and it delineates that anatomy that I showed you perfectly. So the peripheral zone is this bright signal on the T2weighted imaging. Men, all of you men in the room who are over 50 or older, many of you will suffer with BPH, or benign prostatic hypertrophy. That darn disease, that BPH, is something that makes it really hard to look for cancers, because BPH distorts the transition zone, and it creates these rounded nodules. Benign prostatic hypertrophy is glandular tissue that forms nodules, and it makes it tricky. But we're going to talk about that in a minute. Do you have a question, or just stretching? Just stretching. And then no problem at all. We should all stretch, actually. Maybe we will later if If we get bored, we'll. Anyway, the anterior fibromuscular stroma is up top. But you can see that it gives you a clear distinction between the peripheral and the transition zone. Most cancers, as we said before, 85 to 90 to 92% are in this peripheral zone. But we have to learn we have to spend a lot of time looking at this more challenging transitional zone. So what does tumor look like? This is a tumor that would be missed on biopsy because it's so far anterior, and it looks like a dark focal low signal against the regular high signal glandular tissue on T2weighted imaging. So again, the T2weighted images is the most useful for looking for the neurovascular bundles to assess extracapsular spread. This is a patient, here's his normal peripheral zone, and here's his cancer, which is a big cancer, and here you can see a normal neurovascular bundle right there. Here the neurovascular bundle has been enveloped by the cancer as it's spread outside of the gland. So there's asymmetry of the neurovascular bundle. That's what that stands for. You can see extension into the periprostatic fat. And then these are the seminal vesicles. The left seminal vesicles are normal signal, high T2. Seminal vesicles are usually filled with fluid. This on the right, the seminal vesicle is filled with cancer cells, unfortunately, so it's dark. And then the little nodes adjacent to the seminal vesicles are also a sign of extraprostatic extension. So that is the dominant sequence to look at the transition zone, the T2weighted sequence, and I'm going to show you that in a minute when we talk about PIRADS. The diffusion-weighted imaging is the dominant sequence for the peripheral zone. So when we're looking at where the 90% of cancers occur, this is just a beautiful, beautiful sequence. And it's a physiologic sequence, so instead of just anatomic, it's looking at how tumor cells turn over. So what we talked about, again, just on that histologic slide, when cancer takes over a cell and sucks the water, the normal water content out of it, it's going to make the cell more disorganized and smaller and restrict the diffusion of a normal cell. So that's exactly what we're looking at. So it restricts the motion of the cell, and it correlates beautifully with cell density, the normal permeability of the cell membrane, going right back to high school biology, and the space between the cells. And this is back in the 80s when MR was first introduced and was not very helpful. It's sequences like these, physiologic sequences, that are making MR a useful study, and a very useful study in some cases. So along with the diffusion-weighted imaging, which shows this high signal area in the peripheral zone where the cancer cells are restricting the diffusion of the gland, you also get an abnormality on the ADC map. The physics of that is a bit hard, and every time I explain it, I do it wrong. So if you want to talk about it, I'll do it after, because it takes me forever to talk about it. But the low ADC map, though, is very important because it's been shown, and every study that's been coming out has been adding on to this thought that it is helping us decide which of these tumors are aggressive and which of these are maybe less aggressive or more indolent. The measurement of the ADC score is helping to tell us that, and that's what the New England Journal wants us to do. They want us to find a way to find these indolent cancers and leave them alone, find these more aggressive cancers and treat them. So that's one use of this sequence. Those are the two most important sequences of the multi-parameter MR imaging, the T2weighted imaging, particularly for the central portion of the gland, and the diffusion-weighted imaging, particularly for the peripheral portion of the gland where most of the tumors are. So contrast-enhanced imaging, and again, the prostate gland is an anomaly with respect to the rest of the body. With respect to the rest of the body, if you think of the liver, every liver tumor, the way it enhances will help you decide what that tumor is, will help you diagnose the tumor. Contrast-enhanced imaging is a tertiary, the third thing. It's a positive or negative. It's not even a true, it's the third thing that you look at, the fourth thing that you look at, actually, when you're looking at a prostate MR. And it's a plus-minus when we go through PIRADS, which is what you were talking about. So you give gadolinium, which is the same contrast-enhanced contrast study that we use for every other body part. You do a series of T1weighted images from 20, 40, 60, and 90 seconds. And again, what you're trying to look at is tumor angiogenesis. So when you've got a prostate cancer, the cancer has distorted the cells. It's also brought in those new blood vessels, which will cause that part of the gland to enhance earlier than the rest of the gland, and also to wash out quicker than the rest of the gland. And that makes a lot of sense because you've got all these new vessels that the cancers have developed, so all the contrast comes into the gland quickly. You've also got all those vessels that will help wash the gland out quickly as well. So early enhancement and early washout are the findings that you're looking at compared to the rest of the prostate tissue. It's the most useful in the cases that are equivocal, and PIRADS 3 means equivocal, and I'll talk to you about that in just a minute. So in Calgary, what are we using our new, or our quote new? We've been doing it since 2012. We've been working on it since 2011, and we're getting pretty good at it. We're not perfect again, but we're getting confident in it and learning more still. So anyways, in Calgary still, local staging, you've got a prostate cancer, you're going for surgery, the surgeons will ask for MR to look to make sure that you don't have extra prostatic extension before. If you do, they probably will still take you to surgery if that's something that you want, but your chances of having, excuse me, metastatic disease after will be slightly higher. The most exciting part that we're using it for is the cases that I'm going to show you, patients with rising PSAs and continuing negative biopsies. So we know the biopsies are, or we think the biopsies are probably missing the cancer. This will show us where the cancer is and will guide the next biopsy. And some of you have had that already, and hopefully that's going to be something that we're going to use in the future, and the future is now, really. And also our third indication is predicting aggressiveness, and this is where we're still not great, but we're getting better. So some of you know about PIRADS, Prostate Imaging Reporting and Data System. Any woman in the room who's older than 40 or 50 will have had a mammogram, and everyone who's looked at their mammography report will have a PIRADS category, which is Breast Imaging Reporting and Data System. So PIRADS has taken this from breast imaging because the breast imaging screening has been so successful, and they've based the prostate imaging on this. It was initially introduced in 2012 in Europe, and that was PIRADS 1. It had a lot of problems, a lot of difficulty, because what you want in any imaging is every radiologist that looks at the case will report it the same way. You don't want one radiologist saying, that's a high-grade cancer, and one saying, I don't see a cancer there, because it's useless. You want everybody to see the same thing. So the 2012 had some problems, but it was really promising. And then in January 2015, they introduced PIRADS 2, and they introduced it early because it was so successful. The changes that they had started to make in the PIRADS 1 were so successful, and they were becoming so helpful that they introduced this as a working document. So it's still a work in progress, and it probably will be a work in progress for a decade or 2 decades, but it is the future of prostate imaging. And it was introduced to expedite the transfer of high-quality care. And so when they were doing PIRADS 1 and figuring it out, it was in the major institutes in the U.S., so Duke, Harvard, UCSF, the 12 major academic centers in the United States, but also all of the academic centers in Europe and the University of Toronto. So the University of Toronto is like incredibly up to date and a very, very good resource for us as well. Its major goals are to expedite the transfer of high quality MR from laboratories to clinical care. We've talked about that, to reduce unnecessary biopsies. So what we're finding now on our patients with active surveillance, we can tell them to do biopsy coupled with MR in 12 months, followed by biopsy in 12 months or 24 months, followed by MR. So we're prolonging or decreasing the number of biopsies that have to be done with their inherent risks. There's no risk to the MR, none. There's no needles, the contrast reactions from gadolinium are case reportable. There's 3 or 4 cases in the literature, so it's a very low risk procedure. So compared to biopsies, it's a very useful study. The specific aims it tells us exactly what technical parameters we have to do. I won't bore you with that, but it tells you exactly what you have to do, and it standardized the reports so that all radiologists and all urologists and all surgeons are speaking the same language. So if you say this is a PIRADS 1 case, everybody knows there's no cancer seen. Nobody has to worry, what does she mean by PIRADS 1? When you say PIRADS 5, it's an aggressive cancer, needs to be treated. It's just like mammography. If you've got PIRADS 1, you're good to go for screening in 2 years. You've got a PIRADS 5, you need to have treatment. So it's very useful in that way. Reduces variability. Everybody reports the same way. You'll see your reports when you get them. They're very standardized now. We're still working on more standardization, but we're doing better. Develops your category of risk. So PIRADS 1 and 2, you're low risk. PIRADS 4 and 5, you're higher risk, and I'll show you that in a second. Oops. And then it helps us talk to each other as medical people and as people who are trying to educate our patients, because you need to speak the same language so that if you go to the United States and get a second opinion, they don't say, what are they doing up there? They say, oh yeah, I know exactly what they're doing. I can see exactly what image parameters they've used, and it just helps with the communication throughout everywhere. So what are the categories? They're 1 to 5. 1 and 5 are easy. 1 is, I don't see any cancer whatsoever. It's probably benign. 5 is, I'm very worried about this, and I think there's a cancer there. PIRADS 2 is a tricky one. That's usually where BPH sits in. Clinically significant cancer is unlikely to be present, but not 100% sure. PIRADS 4 is the same as PIRADS 5, it's just the size of the tumor is different. So in PIRADS 5, the tumor is bigger than 1.5 centimeters. In PIRADS 4, the tumor is smaller than 1.5 centimeters. That's the only difference between those two. And then we've got our 3s, which are the ones that you spend all day thinking about and weeks worrying about because you just can't figure them out. That's where PIRADS 3 is the only sequence that we really use those contrast-enhanced images because we use them as a positive or a negative to move things up or down. And again, our assessment category is based only on our imaging. We do look at the PSA and we do read about the digital rectal examination, but we don't use those to help us interpret. We do think, well, obviously when I see a patient who's got a PSA that's gone from 8 to 15 to 30, if I don't see a cancer, I'm like, where is the cancer? Because I know there is one, but we don't use it as part of our interpretation. So I'm not going to go through all of this, but I'm going to show you what we're looking at here. This is for each part of the gland, for the transition zone and the peripheral zone, you get a PIRADS category. The higher category is always the one that is used. So we're looking here only at the transition zone, and we're using our T2weighted images. So on the T1 weighted images, that transition zone is just a nice gray, homogeneous blob, and we don't have anything to worry about in it. In PIRADS 2, these are the BPH nodules that we talked about. So it's a little bit busier, a little bit harder to look at. If you've seen enough of them, it's okay. Let's go down to the PIRADS 5 cancer. It's a bigger than 1.5 centimeter cancer sitting right anterior. It's a kind of non-circumscribed, so it's hard for you to draw the exact margins about the tumor, and it just looks ugly. See, it won't even let me stay on it because it looks so ugly. PIRADS, sorry guys, I won't talk. The PIRADS 4 is the same, just a little bit smaller, and then PIRADS 3, you can see it's just hard. It's usually patients with BPH that are kind of extrinsically compressing their peripheral zone, so even the peripheral zone starts to look funny, and it's just a hard gland to interpret. Just a couple of bigger images. This is a PIRADS 1, easy to interpret, so just to make sure we know what we're looking at, those are the symphysis pubis, your pubic bones, a little bit of the bladder, just anteriorly, usually it's decompressed. There's the prostate gland and there's the rectum behind it. So transition zone in this patient is easy to interpret. It's just a gray blob, nothing worrisome in it. And here's a large cancer anterior. You can see the margins are irregular. It's hard to put your mouse or your finger or anything along where the margins are. And you can see the BPH nodules behind it. No cancer for this person in their peripheral zone. Nice and bright T2 signal in the peripheral zone. The peripheral zone is scored also on T2weighted imaging as it predominantly looks like a bright homogeneous signal in a normal gland, and then when you've got a cancer, it again looks like a black heterogeneous ugly looking thing. So again, the peripheral zone is a bright, smooth, uniform signal, and then PIRADS 5 is this kind of ugly, dark, just like cancer sounds, right? Ugly, dark, ill-defined, invasive type of thing. So the diffusion-weighted images have the exact same categories. So PIRADS 1, no abnormality seen, there's nothing abnormal. PIRADS 5, a large tumor that shows restricted diffusion. So restricted diffusion here, and a corresponding abnormality on the ADC map. Here's a normal gland. There's literally nothing. This is a little bit of artifact. This patient has an endorectal coil in, so there's a little bit of artifact there, but the whole gland itself is homogeneous. Nothing showing abnormal motion of cells. So not everything in the prostate gland is cancer. A lot of it is, but when you start to look at MR, you have to know some of the other, I'm not going to go through all of these, I'm just going to put them up. Those are the things that can mimic cancer, and so it takes a little bit of experience to be able to interpret the MR to make sure that you're not calling something a cancer that could just be an anatomic variation. And so, again, the more experience that you get, the more cases you've seen, the more mistakes that you make, the better you become at interpreting these. There's innumerable articles on radiologists be aware, pitfalls that can confound, because it's not simple, but it's definitely doable. So I'm going to show you a couple of cases that made a difference in patients' lives, and they're from here. They're all anonymized, just with your ULI, your Alberta Health Services number, but there's no names on any of these cases. But I have put some of the requisitions in just so that you can see how we're being used now by the urologists and by how our technology is helping. So this was a patient who was 69 years old. He had a rising PSA up to 28, and he'd had 2 previous biopsies. So these are our images from the Rocky General Hospital, 1.5 Tesla magna, so a lower strength magnet. All of our prostates, almost all of our prostates now are done on the 3 Tesla magnet over at the South Health campus. So we have 2 sets of images here. This is a sagittal image. So if you're thinking of drawing a line through the side of your body from head to toe, you'd be taking straight through the center here. So here's your sacrum, the lower part of your lumbar spine. Here's your bladder, here's your rectum, and here's your prostate gland. So there's that symphysis pubis there. And here's the tumor, which is very anterior. And you can imagine that the rectal probe for your transrectal guided ultrasound had gone into your rectum, and it had taken a large part of the gland, but it had missed this anterior portion of the gland. So again, on the axial images, which are front to back, so here we're going through the symphysis pubis frontwards. Here's your prostate gland and your rectum. Your rectal probe would have been here, coming up through the rectum, and you would have taken a series of biopsies around, but you would have missed this anterior tumor sitting here. This is what we see often. So on these T2-weighted images, we're very worried about this. We would call that a PIRADS 5 tumor. Our diffusion-weighted imaging. On the 1.5 Tesla magnet, it's not quite as powerful. Not quite as powerful, so that's not quite as bright as it is on the 3 Tesla, but very dark on the ADC map, very bright on the diffusion-weighted imaging. We asked the interventional radiologist to target that area specifically. So it's so-called cognitive fusion. Some of you will have heard of MR fusion. This is cognitive fusion. So you take your brain and you look at the images, and if you've got a lot of brain and good images, you put them together, and that's called cognitive fusion. And you direct your targeted biopsy there. Got a Gleason 7 at both apices, so anterior at the apex. 50% core on the left, which kind of fits with, this is more left-sided. The great part about this is this is the Tom Baker consultation note from July 29, 2015. So we do a lot of work with the oncologists as well. And I just read this and I thought, this is exactly what we're hoping to do, is to convince our colleagues, our medical oncology colleagues and our urologists and surgical colleagues that we can help them. So you do 3 random core biopsies in 2011, 13, and 14, and they're all negative. And the patient's PSA is gradually rising. So we're worried because it shouldn't be rising. So he had a prostate MR which showed this abnormality, and this is a quote from the oncologist that said, "A good reason why the biopsies were negative as this was not sampled in any of the previous." So it's very satisfying as an imager to get that. This is another case, August 28, 2015. Intermediate risk prostate cancer. So he's had a random core biopsy that showed a PSA. The urologist has shown a T2A, so he staged it as T2A with a left nodule, and he feels a high volume on the left side. So he wants to take him, this is one of the surgeons that some of you may know, he wants to take this patient to the operating room, but he wants to know if he'll be successful, so he wants to know what about extraprostatic spread, and this is a common indication now. A young patient, so you want to be really, really sure of what you're doing. So here's an axial T2weighted image. Just again, we're coming through a little bit of fat along the anterior abdominal wall. This is the bladder, and then these are the seminal vesicles, and the seminal vesicles should be filled with fluid. We ask men to not ejaculate for at least 3 days before the MR because we want their seminal vesicles to be full. When the seminal vesicles are empty, they're dark, which doesn't help us, but if they're full, they're bright, which helps us. You can see the right seminal vesicles are bright and filled with fluid, but the left are dark, and that's worrisome. You're not happy when you see that at all. And you come through and you can start to see that this left seminal vesicle is tethered. That's not good either. You don't want to see that. And then you start to come into the prostate gland, which is actually a small volume. It's probably less than 30 cc's. But you don't see any of that normal, bright, peripheral T2 signal. Instead, you see that kind of ugly, dark, irregular, ill-defined tumor. Here on the right, you start to see more normal peripheral zone. You see a bit of BPH, these glandular nodules, but this is a big tumor sitting there. So we say to the surgeon, we're worried about this case. Oh, sorry, the rest of the case. Do you have a question? No, it's just stretching. This is the T2weighted image that shows the dark T2 signal, the abnormal restricted diffusion, and the corresponding abnormality on the ATC map. And these images may look a little bit ugly because they're done on a 1.5 Tesla magnet, but they're diagnostic and they're very helpful. As I said before, we moved to the 3T, but these images were helpful. He went on to have, he's only 64, went on to have the radical prostatectomy, and there was extraprostatic extension as we thought. It was quite extensive. The seminal vesicle invasion was present. It was bilateral. It was quite extensive as we thought. But he had a robotic prostatectomy. He widened out the surgical margins pre-intervention, which he wouldn't have done if he hadn't had the MR, and the resection margins were completely negative for malignancy. The patient is still doing well in 2015. So although not a great looking MR and not the greatest, not the greatest diagnosis that you can have, the MR was incredibly helpful in that it changed the surgical planning. It made sure that he took everything that he could possibly take, and hopefully a cure for this patient. One last one. This guy's even younger, 56 years old, rising PSA 2 negative biopsies. So here's the kind of clinical information that we get. He had a random core biopsy in August 2014. His PSA was 5.2. His gland volume was 31.7. PSA density was 0.17. PSA density of anything around 0.2 and higher, you worry about. If somebody's got anyway, that's another screening study that I'm not going to talk about. But his entire random core biopsy in 2014 was negative. So benign prostate, so the 6 core sextants of which they took 2 samples of each, benign, benign, benign with changes related to previous biopsy. This is a benign diagnosis, a histologic diagnosis, no cancer there yet. Benign, benign. So by 2015, PSA continues to rise, so 5.2 to 8.1 to 9.1. Another one of the surgeons, Dr. Duffy, I think Is his name on there? Oh, he always puts his name on there. Anyway, Dr. Duffy, this is his case. So I'll show you the three things. So here's the T2weighted image again. That's the symphysis pubis, the start of the prostate gland. And the peripheral zone, again, looks good. This is the rectum back here. Again, this is where the rectal probe would have been. Again, this is an anterior tumor, and that's a theme that we see over and over again. The anterior tumors are missed mostly, are very commonly missed because of where that anterior portion of the gland sits with respect to the rectum and the limitations of the transrectal probe. So again, this is a PIRADS 4 lesion. It's only, I think it was 12 millimeters, so anything less than 15 millimeters is PIRADS 4, anything greater than 15 millimeters is PIRADS 5. So it's dark on the T2-weighted images, very, very bright on the diffusion-weighted imaging, and very dark on the ADC map. So worrisome for a higher grade, but we don't know for sure, but we know for sure that that's a cancer. This is the contrast-enhanced imaging on this particular case, just to show you that the cancer enhances. So just to give you a bit of perspective, these are the femoral arteries, these guys on both sides, and you've got some other small vessels. But this portion of the prostate gland enhancing almost as much as the rest of the big arteries in the body. The rest of the prostate gland has not started to enhance yet. So that's a pretty positive contrast-enhanced study. By about 90 seconds, by about 60 seconds, the rest of the gland starts to enhance, almost the same. And this part of the, this where the prostate cancer is starting to wash out more quickly. So this person, again, had the cognitive fusion biopsy. So I put the biopsy images, that's the rectal probe, and there's the rectum right there. So the rectal probe goes in, and I think I put the biopsy image, yeah. So Dr. Welsh, one of our friends here, has had some experiences with Dr. Welsh, and he's done the majority of these cognitive fusion, and he's so good. He's just, he's so careful, and he's so good. If you can ever meet him, he's just one of my favorite people, because he just cares so much about what he does, and he takes so much time, and he's so happy when he gets these successes. So remember, this patient had multiple negative biopsies, rising PSA, had this cognitive fusion where the needle was put exactly into the cancer, and the diagnosis was then made of a Gleason 7. So an absolutely beautiful case that we had. Went on to have surgery, and a beautiful result for everyone, because it was negative for any spread of disease, negative for extraprostatic extension. The resection margins were negative, and it was a P2 cancer, T2 cancer, which is the best you can hope for in this particular situation. So that's all I'm going to probably talk too long. Did I? I lost track of time. I can talk forever, as you probably guessed. But that's where we're at right now. So we've reviewed the diagnosis again, just because it's important to know exactly what you're dealing with. Where we're at the Alberta Health Services, we certainly have them on our side for MR, because we are making a difference. So we're going to keep moving in that direction. Anyway, I do have one last joke, which there it is. I showed it last time. I've seen it before. Anyway, I really do appreciate being asked back, and it's lovely to see some familiar faces. So thank you for having me. I'm sorry I kept you so late. I've lost half my audience, but thank you.